Welcome, everyone. Thank you for coming to our Tuesday Let's Talk Menopause talk. Everything you wanted to know about menopause, but we're too afraid to ask with Dr. Vanessa Soviero. I'm Alessandra Henderson. I am the Senior Program Advisor to Let's Talk Menopause, and I'm thrilled to be working with this incredible team on educational programming. Let's Talk Menopause is a national nonprofit changing the conversation on menopause to ensure women get the information they need and the healthcare they deserve in midlife and beyond. Today, we're joined by board-certified OBGYN and menopause expert, Dr. Vanessa Soviero, for a candid, no-holds-barred Q&A discussion answering your top menopause and menopause questions. I will introduce Dr. Soviero because she is wildly impressive and we're thrilled to have her here, but want to set the stage on what you can expect before diving in. So we'll spend about 25 minutes answering questions submitted by our community. Thank you very much to those of you who submitted. We'll walk through those in detail. We invite you, as you are listening, to submit your questions in Slido, which should appear on the right side of your screen. We will do our best to answer all your questions, but I can say the time goes quickly and we'll probably, it can be hard to get through everything. We'll do our very best. And we appreciate your patience if we can't get to yours. And a reminder that we're not able to offer personalized medical advice. We can't answer unique medical questions. So as you ask a question, please try to keep it at least broad so that it might apply to others as well. These menopause talks are central to our education efforts to ensure women receive menopause information from leading experts. If you like what you see, we have over 30 talks on our website. And a reminder that these talks are intended for informational purposes only, not as a substitute for professional medical advice, diagnosis, or treatment. A big thanks to our sponsor, Bayer, for making these available. Just a handful more before we dive in. So please submit questions in the Slido app. There will be a brief survey, and we will send out a recording of the event to everyone who RSVP. So with that, we know that less than 20% of OBGYN residency programs offer menopause training at all. 40% of women who seek menopause care leave without treatment. So we are here with expert Dr. Vanessa Soviero to answer these questions. Dr. Soviero is, as I mentioned, a board-certified OBGYN who serves as a gynecologist, a menopause educator, and medical director for a multi-physician practice at Northwell in New York. Her focus is in perimenopause and menopause, treating patients with menopausal issues and educating medical professionals to provide care. She's an active member of the Katz Institute for Women's Health in New York and is bilingual, which expands her reach to the Hispanic community. Incredibly important work. She's a passionate advocate for women's care and empowers women to seek the care they need, require, and deserve. Welcome. Thank you for being here. Would love to just start, if you could introduce yourself and your unique background and a little bit of the path that led you to study and practice OBGYN and menopause care.
Well, I'm an OBGYN by training. So up until 2017, I was delivering babies like every other obstetrician until I had some medical issues of my own where I had to stop delivering babies. And then I was in the office 5 days a week, seeing only gynecological patients, seeing perimenopause and menopause, and realizing I was not prepared. I did not know really how to address the issues. So I had to seek my own training for menopausal care. And I did go to the Menopause Society. I seeked my training. I seeked my certification. And now I'm fortunate because 5 days a week, since I don't deliver babies anymore, this is what I do 5 days a week now.
Amazing.
Yes.
We're all the better for it. I'm just going to dive in because the hour goes quickly. So we again have some top questions, but please share them in Slido if you have more or need clarifying. Maybe at the top of this, can you talk about chest pain? So there are questions around heart health, but also very specifically heart palpitations and chest pains in menopause. How can you tell and distinguish between heart-related versus menopause?
That's a great question. Every single day, I have women coming in reporting palpitations. Chest pain is different. Anyone with chest pain should seek care by their primary care physician or a cardiologist. However, palpitations are a very common symptom of menopause or perimenopause. So for many of those patients, we're obviously doing a detailed medical history to see if it sounds like it's more of a cardiac issue or if it's menopause related. But many women do have palpitations. And for many of these women, if it doesn't sound like there's underlying heart issues, for many of us, we'll start them on hormone therapy. And if when they come back in 2 to 3 months, if they're still having that symptom, then they absolutely should then see a cardiologist if they did not already. But it is a very common symptom that majority of the time can resolve with hormone replacement therapy or menopausal hormone therapy.
Perfect. Thank you. I'm going to just dive right into menopausal hormone therapy or MHT, because a majority of the questions from the community are around that. So let me walk through those here. Can you start at the top of this with telling us what's the difference between systemic and local MHT?
Also a great question and very important for everyone to really understand. So systemic hormone therapy is how we treat symptoms of menopause, such as hot flashes, night sweats, sleep issues, joint pains, brain fog. All those issues are treated with systemic hormone therapy. And with that, we do get levels of hormones in the blood so it can improve all the symptoms around the entire body. There's different ways we give those hormones. There's either patches, there's sprays, there's gels, there's a ring for the vagina, and there's oral therapy. There are very rare risks to systemic hormone therapy, very rare. When it comes to local therapy, many women may not have hot flashes or night sweats anymore, or many women may only have vaginal symptoms, which include vaginal dryness, pain with sex, urinary symptoms, urgency, frequency, recurrent UTIs. So for those women, you don't need systemic estrogen therapy. You need local vaginal estrogen therapy, which is very safe. There are no risks to vaginal estrogen therapy. So we'll talk about it later, the unboxing. There's a FDA warning that comes in the vaginal estrogen boxes that tells you there's a risk for vaginal estrogen therapy, and that is false. That is not correct. So even with a woman with a history of breast cancer, heart disease, anything, it is safe to be on vaginal estrogen therapy.
Okay. Well, a question from the community. My latest mammogram showed I'm at a higher risk of breast cancer. Can I still be on hormone therapy? So maybe
Yeah, so
talk a little bit about that, specifically if mammograms show, but also broadly the risk of breast cancer and menopause hormone therapy.
So before we talk about hormone therapy, it's very important for women, for us as providers, to know your family history, your personal medical history. Are you up to date with your own screening? So if you have a quote unquote increased risk for breast cancer on your mammogram, that could mean a bunch of different things. And as long as we do not think you have breast cancer, that is not a contraindication for hormone therapy. The only contraindication is to have actual breast cancer.
Okay. And so that is a conversation with your provider in terms of there are screenings and, not just the mammogram in isolation, but
and it depends why the mammogram is saying you're at increased risk. Is it based on your family history? Is it based on the density of your breast? Did they see something that is actually suspicious? So it really depends on the details of that imaging report.
Okay. Can we talk about a bit around menopause hormone therapy and perimenopause? So the question is, can women start menopause hormone therapy during perimenopause for symptom management?
Yeah, so the difference between birth control and menopausal hormone therapy is really the type of hormones we use and the dosages. So the dosages in menopausal hormone therapy is much lower. Perimenopausal women who are having symptoms, even if you're having regular periods, need hormone therapy. Now, depending on other issues, are you also having bleeding? Do you also need birth control? A very common recommendation would be birth control because those hormones would alleviate your symptoms. But for some women, if you cannot be on birth control, if you do not need contraception, you can also take menopausal hormone therapy, meaning just the lower doses for symptom relief.
Okay. So that's important to double down on, that you can still take menopause hormone therapy. So be it patches or creams or certain, because the second part to that was that their provider said that it could still cause bleeding and that birth control is the only option until menopause. That is What you are saying, just to again reiterate, is that that's not true and to investigate further.
Right, that's not the only option. The other thing that's important to know is in perimenopause, abnormal bleeding is very, very common. Sometimes, depending on the bleeding pattern, you still have to make sure you have an appropriate workup to prove that you don't have any underlying conditions that are causing the abnormal bleeding. Having said that, if your workup is negative and you do not have precancer or cancer, hormones are typically the way we treat that. And because menopausal doses are lower, menopausal doses will treat your other symptoms, but are not high enough doses to control abnormal bleeding.
Okay. Sticking in the perimenopause phase here, if a woman has an IUD, how does one know if she's in perimenopause?
Okay, so having an IUD, it depends on the type. So there are two types of IUDs. There's a progesterone containing IUD, and there's the copper IUD. If you have the copper IUD, you will continue to have your periods. But many women with the progesterone containing IUD, also known as the Kyleena or the Mirena, many women don't have periods anymore. So we go by symptoms. If you're not getting any more periods because you have the IUD, but you don't have any symptoms, then it doesn't really matter if you're in menopause or not. But if you're not getting periods and you don't know if it's from menopause, but you have symptoms, then we treat your symptoms.
Okay, that's helpful. And if you can, I'm going to go back a bit. Sorry, I'm jumping around. There are a couple of questions, so many questions coming through, and not just in the Slido here. So bear with me as I just sticking on this. When does one consider switching from birth control to MHT?
So
And I'm
if someone
assuming that
wants,
this is oral as opposed to IUDs, but how do you think about that transition?
so the average age of menopause is 52. So assuming you don't have any medical problems where you cannot stay on birth control, a lot of us will keep you on birth control until the average age of menopause, which is 52, and then have the discussion of, we can transition you to that point to menopausal hormone therapy. There are providers that will even let women, assuming no other medical conditions, take birth control up until 55, where vast majority of women will be in menopause at that point and then transition over to menopausal hormone therapy.
Okay, that's helpful. As you're thinking about building out what your menopause hormone therapy regime is, how do you decide what how to dose? And then there was a very specific question also around daily versus sequential progesterone, which I know is more narrow, but how do you think about where do you get started?
Okay, so it is very different for every patient. So basically what I think is very important is that every woman know all the options of therapy. And then at the end of that conversation, we decide what are her worst symptoms, how does she think she'll be more compliant with the medication, and what regimen works best for her. So for every patient I have in front of me, I go over all the methods. So let's say we're talking about menopausal hormone therapy. If we're talking about systemic options, I mentioned that there are oral methods. There's the patches, which are once weekly or twice weekly. There's sprays and gels, which are daily. And there's a ring that can go in the vagina that's every 3 months. That's for the estrogen. So we first decide what they prefer. Some people don't want a patch because they may not want it to show in their bikini, or some women may want the ring because it's convenient and is every 3 months. So it is very patient specific, but I think it's important that they know all the options versus if you go to a doctor and they just hand you a prescription saying, here's your hormone therapy and let me know how you feel in 3 months. They need to give you options so you can decide what's best for you. So when it comes to progesterone, so estrogen is what we need for the symptoms of perimenopause and menopause. Progesterone is a hormone that we need to protect our uterus. So if you've had a hysterectomy, if you have a Mirena IUD, you do not need to take progesterone because the progesterone is in the IUD, or if you have a hysterectomy, you don't need to protect your uterus, you don't have it. So most of us prescribe oral progesterone, and that's the bioidentical one is called progesterone. We tell women to take it at bedtime because a side effect of it is sleepiness. So a lot of women who have sleep issues, you take the progesterone, it's protecting your uterus and you're sleeping. They used to prescribe that what we call sequentially. So what that patient is referring to is people were once told you could take the progesterone for 2 weeks and then you don't take it for 2 weeks. A lot of women who do that are women who have bleeding issues and they want to have a predictable bleed versus random bleeding. If you don't have any bleeding issues, I personally think it's easier to take it every single day, because if you forget to take it, then you're off schedule. So most of us prescribe the progesterone daily. Plus, if it's helping you sleep at night, you don't want to sleep great for 2 weeks and then not take it for another 2 weeks. So that's the difference. Most of us do it daily because it's easier to remember, but sequential is an option if you're having bleeding on the hormones.
Okay. Very helpful. So many combinations.
Yeah.
And
Well, that's what it is. It's individualized. Every conversation is different for every single patient.
yeah, yeah. And it's a lot for women to wrap their heads around, but
Yes.
finding and I think Donna and my team and we'll be sharing links to understanding what are some of the industry guidelines and where to find a menopause practitioner who, like Dr. Soviero, who can actually work together with you as you're iterating on this management, which we know the other thing too is you might find a regime or prescriptions that work well for you for a certain amount of time, and then new symptoms might evolve.
Yes.
With that, we actually got some questions of, how do you know if you need to, there were two related, but how do I know if I need to increase my dose? I've started on the lower dose, but some symptoms have gotten better, others have not. And then there was a related question, which is I've been on, menopause hormone therapy for 2 months, but it's taking too long to find relief from insomnia, brain fog, fatigue, hair loss, and more. So yeah, how do you think about iterating the dose?
So we do everything for symptom relief. So a lot of women come in asking for their hormones to be checked. They're on the hormones. They want to know what they are. We don't treat levels, we treat symptoms. So if you are on a low dose and you come in for your follow-up and you're still having symptoms, that's when we have to either discuss going up on your dose or maybe changing the way you take it. But it's all based on symptoms. And then what was the second part of that question again?
So it's symptom. How do you know if you need to increase your dose? But let's say you're on hormone therapy for 2 months and you're not seeing relief, and they named specific brain fog, insomnia, fatigue, hair loss.
So many women actually experience relief fairly quickly within a couple of weeks, but it can take 2 to 3 months to notice improvement in symptoms, or you may feel a little bit better, but you're not better enough, which is why, especially in the beginning, it's very important that you have follow-up. I have my patients come back in 3 months. And then if at the 3-month mark, they're still not better, then we talk about, again, either increasing the dose or changing the way they take it. But maybe you just haven't been on it long enough to see all the benefits you'll receive.
Okay. Can we talk about potential side effects?
Yeah, so basically, I always tell women common side effects can be irregular bleeding for the first 3 to 6 months. Even if you are still getting your periods, if you haven't had a period in 3 years, irregular bleeding is not uncommon. Any bleeding that persists after the 3 to 6 month mark requires a full workup. Make sure there's nothing else going on. Breast tenderness is very common. Bloating is very common. I tell women, pretty much a lot of women can feel PMS-like symptoms when they first start the hormones. And they
There was a question, hold on, I'm going
to
interrupt you, didn't mean to interrupt your flow, but there was a question of how long can one anticipate for that to last before, is this normal or not?
Again, typically, most people don't have symptoms for that long, but they can be 2 to 3 months.
Okay, thank you.
Yes.
Anything else? I didn't mean to interrupt, but the specific with how, I have experienced breast tenderness, how long should this last?
Again, it's usually temporary, but yes, it can last 2 to 3 months potentially.
Okay. Speaking of, and if this is side effect or not, but started hormone therapy a couple of months ago and experiencing quite a bit of weight gain, especially in my belly. Any other recommendations or causation with the hormone therapy?
So it's most likely not the hormones that are causing the weight. The dosages that we use for menopausal hormone therapy are extremely low. But what I tell my patients every day is that the hormones also, unfortunately, don't stop the weight gain process of the transition of menopause or perimenopause. So we think that women who take hormones would gain less weight than if you weren't on hormones. But it doesn't, unfortunately, it doesn't stop your body from gaining the weight or changing your body composition, even if you go on the hormones, unfortunately. I use myself as an example. I thought I was going to outsmart menopause and put myself on the menopausal hormones before I actually went to menopause. And I still got a menopause belly, even though I started it before I even went through
You
the
look
treatment.
great. I've seen you. I just saw
Oh
you
my
two
God,
weeks
thank
ago.
you.
You look great.
Thank you.
Yeah. Well, there are questions around non-hormonal treatment. I promise you, just for those listening, this is not just going to be a menopause hormone therapy talk, but this is where we're going to try and tackle them all in one go, and then we'll move into non-hormonal treatments. And we also know that not everyone can be on menopause hormone therapy. So please stick around. We just want to get through the lion's share, and then we'll move on. But speaking of, while we're on that menopause belly, are there studies on GLP-1s and menopause hormone therapy?
You know, there's not much stuff out there yet, but I do frequently recommend. I'm fortunate. I work for Northwell with the Katz Institute. We have a menopausal health coach that does help women talk about, their diet, their exercise, our nutritional and physical needs change as we transition into menopause. But for a lot of women, by the time they're finally seeking treatment, they're already a few years into the process. They've already gained 10, 15, 20 pounds, maybe more. So for a lot of these women, I do also recommend that they see a weight loss doctor so that they can be on the GLP-1s, because we know there are benefits, whether there's actual studies with menopause, honestly, not 100% sure, but I do have a lot of my patients also seek treatment for the weight loss part of it as well, because it's a
Yeah.
very frustrating part of the transition.
It is. And I will say, I can't remember off the top of my head exactly to quote it, but there was a smaller study that came out, I believe, last year or 2 years ago, with looking at menopause hormone therapy in combination with GLP-1 use. And there's a question around semaglutide shots. There's a number of different types of these weight loss medications, but that actually the combination of the two improved outcomes, and by that meant higher weight loss and improved kind of longer term outcomes over the 3, 6, 12 months. So it just feels like we're at the start of this, of understanding.
Yes, absolutely. Absolutely.
Yeah. Okay. Hold on one second. I am just going through these. Can we talk a little bit about, there was a question around progesterone and mood, actually. Does progesterone impact mood?
It can, as a side effect, like the progesterone can cause mood issues. Also, fluctuating
Or
estrogen.
positively? I guess the question was also too of
well,
the
yeah.
positive combination with estradiol as well. So
Yeah, so basically for many women, especially perimenopausal, it's the fluctuations of the estrogen, the progesterone that are causing a lot of the symptoms, including the mood symptoms. So yes, estrogen alone can improve depression, anxiety, any of these mood symptoms in perimenopause. But yes, if you're perimenopausal, yes, the fluctuating progesterone can also affect your mood. So yes, when we supplement it, it can help that, which is why a lot of times perimenopausal women do require a higher dose of the progesterone. So in perimenopausal women, we don't only use the progesterone for uterine protection, but sometimes we need higher doses just also to balance some of the symptom relief.
okay.
So yes, it can help that.
Well, we're talking about mood. There was a comment/question here, which I feel like so many women can relate to. So I'll just share this of, how can I help my anxiety, which seems to be taking over my life? I'm 53 and experiencing irregular periods. Yeah. What do you think about?
Anxiety, worsening anxiety, depression is a very common symptom of perimenopause and menopause. A lot of women are going to go to their gynecologist, they're going to go to their primary doctor, and they're just going to throw them right on some antidepressant, anti-anxiety medications. And in many women, you actually need your hormones. So whether you're perimenopausal, and if you're still getting irregular periods, you are perimenopausal, the fluctuations cause significant anxiety. I mean, I hear some horrible stories every day of women who have this new onset anxiety. They can't drive alone in a car. They need their husband driving with them, and they never had that before. We also frequently see women that say, I've been on the same dose of Lexapro for 20 years, and all of a sudden I have anxiety, I have depression. It's not helping me anymore. So it is the hormonal changes that can be affecting your anxiety and depression. So it's not necessarily an antidepressant anxiety medication you need. It's probably just hormones that you need.
Okay. Can you talk a little bit about testing as well? How do we think about testing either in the perimenopause or 40s to 50s? We know that menopause can be a moving target in terms of age. So talk a little bit about the kind of tests that you might look either in perimenopause or into menopause.
That's a very common question. Every day people want their levels checked. And there is no blood test to diagnose perimenopause and menopause. Some of the hormones we do look at fluctuate on the daily. They fluctuate from day to day, and one day could be normal, the next day not. So we go by symptoms, we go by, cycle changes. So that is the important thing, that there is no diagnosis. Having said that, we do have women. If you're having hot flashes, night sweats, problem sleeping, fatigue, most of the time it's probably perimenopause and menopause. Sometimes it could be a thyroid problem. Sometimes it could be other issues. So when we check hormones, we're not necessarily checking to see if you're in perimenopause or menopause, since there's not an exact test, but we're checking other hormones, thyroid, prolactin, to see if those are the causes of some of your other symptoms.
Okay. Speaking of things to test, there's a question here around elevated cholesterol coinciding with menopause. This woman, but just doesn't have to be, is on HRT, has an ideal diet. What needs to change? Is that a tweak to the hormone therapy, statin research? How do you think about cholesterol in menopause?
Very common also, women come in, I've had normal cholesterol my whole life, I eat healthy, all of a sudden it goes up. So estrogen actually is protecting us from having high cholesterol. So the second we start having perimenopausal changes or lose our estrogen, our cholesterol frequently goes up. So going on hormone therapy is one thing we can do to help the cholesterol. But for some women, once you have the high cholesterol, even going on hormone therapy, it's not necessarily going to reverse it. So it's also important that you see your primary doctor, potentially see a cardiologist, because there are indications for women to be on statins. So that's why we, as the menopause specialists, need to co-manage with the cardiologist or the primary doctors, because yes, in menopause, now because of your cholesterol, even if it's better with hormones, it still may be a risk factor for you, and you still may require a statin.
Okay, thank you. So what are the non-hormonal natural remedies for to help with symptom treatment? And so the question here was diet, exercise, yoga, Ayurveda, acupuncture. It's a big question.
That's a huge question. And it really depends on which specific symptoms, because for vasomotor symptoms, for example, hot flashes, night sweats, problem sleeping, there's something called cognitive behavioral therapy that has been shown to improve those symptoms. Acupuncture works for many women. Not much studies out on it yet. Hypnosis has been shown to help women with vasomotor symptoms. And there's something called stellate ganglion block, which is an injection that someone gets in their neck.
I could not repeat that if you paid me.
And the funny thing is there's not many doctors who even do that. However, there are
What is it? Can you repeat it again?
It's called
what is it? I interrupted.
Stellate ganglion block. And it's like interventional radiologists or pain doctors do it, where they inject somewhere in the neck, and it also helps with the hot flashes and night sweats. That's not really available for many women, but there are those options, and there are non-hormonal medications that are great options as well. Okay. So a lot of the antidepressants, the SSRIs and SNRIs, so Paxil, paroxetine, or like Lexapro, escitalopram, Celexa, Pristiq, in low doses can reduce hot flashes. Not as good as hormones, but they can reduce hot flashes in women who can't have hormones or who don't want to take hormones. There's also a non-hormonal medication called gabapentin. It's a medication that a lot of women take for, let's say, nerve pain. There's also a medication called oxybutynin. So let's say you have incontinence. It's a medication we use for incontinence that a side effect is reduction in hot flashes. There's also a great medication on the market now. It's called Veozah or fezolinetant. It is not hormonal. It actually works in an area in the brain that controls our temperature and is as effective as hormones in reducing hot flashes and night sweats. Very, very, very effective.
That's great. Because as we know, again, whether you have a family, a risk profile or family history, be it breast cancer or actually, can you talk about what some of the risks are that might exclude you from taking hormone therapies that you are looking at? Because there's your choice, right, of, wanting
Yes.
to start with non-hormonal treatment, and then there's some of the risk factors.
So there's a few contraindications, meaning you should not take hormones if you have certain conditions. So one is unexplained vaginal bleeding. Like we said earlier, most bleeding is not precancer or cancer. However, we need to prove that first. We can't assume that. Even though most likely it's perimenopausal, we can't assume that. So once we prove you don't have precancer or cancer, hormones would be an option. You should not take hormones if you have a history of breast cancer or endometrial cancer, because both of those could potentially be estrogen responsive. If you have active liver disease, now many women say, oh, I have a history of fatty liver. That doesn't really count. Active liver disease, you should not take hormones. And if you have a history of a blood clot, a heart attack, a stroke, or if you have underlying what we call factor V Leiden or prothrombin gene mutation, those can predispose you to clots. There are caveats to all those situations. So if you do have a history of that, you really should see a specialist, because certain situations, it is a potential if none of the other non-hormonal treatment options work for you.
Right. Yeah. So really know your family history, know your own medical history, and make that decision from there. But I think, we mentioned a number of, if menopause hormone therapy is not for you, there are a number of different options that are both pharmacological as well as lifestyle and behavioral to be able to.
Which is why it's important for women to know that they're a specialist, because if you go to your doctor that doesn't specialize in this, they may have one treatment only to offer you.
Mhm.
And you deserve to know all of your options, and you deserve to make the choice in what you think is best for you.
Yes. Yeah. And know that this is likely an evolving situation as well, right? In terms of new symptoms,
Absolutely.
perimenopause into menopause, very different.
Very much. Yep.
When can you either start taking menopause hormone therapy, or when is it start, stop, or when is it either too late? There was a very specific question here of a woman who's in menopause and sorry, menopause hit at 52. My symptoms were bad for years, but finally resolved, no hormone therapy. Now at 58, the hot flashes and weight gain, which is new to me, have started. Can I start hormone therapy now?
Yeah, so we always say the sooner the better. My motto is as soon as you're having symptoms, we should be talking about it, because in my mind, there's no reason to suffer. Some people say, I'm just going to tough it out, but that might be 1 year, 2 years, 3 years, 5 years. So my opinion is whenever you're having symptoms, it should be something you discuss, because the sooner you seek treatment, the sooner you feel better. The better, obviously. We also believe that the sooner you start the hormone, so when they look back at some research, they saw that women less than 60, within 10 years of menopause, if you didn't already have any heart disease or brain disease, there were actually benefits, heart benefits, brain benefits, bone benefits, low 30% reduction in what we call all-cause mortality, so 30% lower risk of dying, 30% reduced risk of developing type 2 diabetes. So tons of benefits. And the benefits are greater the earlier you start. Having said that, it does not mean that if you start at year 8, or 9 years from menopause, that you won't have benefits. We can't quantify how much benefit you'll have, but you still can have symptom relief. And even though we quote less than 60 within 10 years of menopause, we can still start hormones. As long as you don't have any contraindications, you can still be started on hormone therapy, even if you're after 60, more than 10 years for menopause. Again, it is a case-to-case discussion. As long as we go over your risk profile, your medical history, your concerns and your issues, it is still an option.
Okay. There is so a question around, can you stay or should you stay on menopause hormone therapy beyond 10 years of menopause? Both. I'm gonna expand on this question, but can you stay on hormone therapy longer than 10 years post-menopause? And also, how do you think about staying on from a long-term preventative?
Yeah. So there used to be really, and based on nothing, they used to say up after 5 years, you had to stop your hormones. Not true. You do not have to stop your hormones. Every year, when you see your doctor for your preventative visit, as long as you're up to date with your healthcare, we're checking your mammo, you had your colonoscopy, you're doing all the things you're supposed to do, and your health is the same, there is no reason to stop them as long as there's no contraindication has developed. And once you stop the hormones, besides the fact that yes, you may develop symptoms, then the protection is not there anymore. So once you stop the hormones, let's say you are on them for osteopenia, while you're on the hormones, we protected your bones from progressing to osteoporosis. But once you stop those hormones, you go back to bone loss as if you weren't on the estrogen. So you may lose the protective benefits, but if you're healthy and you're happy on them and you want to stay on them, you should not have to come off your hormones.
Right.
I'm never coming off mine, ever.
And we know that sometimes the biggest battle, and this is a comment, not necessarily a question, because I know you're not responsible for this, but we do know, sometimes health insurance, or they don't make it easy sometimes, but there are more options that are coming to market now, both in terms of finding a provider who will help, but, advocate with your health plan to make sure that it's covered, or a range of different online telemedicine options as well, to be able to meet you where you are, to be able to stay on. So,
and most of the medications that we use are generic. So, yes, some of the newer medications are going to be more expensive, but these insurance companies, majority of the medications we're prescribing have generics available. So it should be something that every woman has access to.
please don't let that be a barrier.
Yeah.
Continue to push. What about women who do not have symptoms and at 49, perimenopausal, but soon moving into menopause? What about starting menopause hormone therapy despite not having symptoms?
Yeah, that's a great question. And so basically, most women have a symptom. If we do our job appropriately, when you ask the questions, they'd be like, oh my God, I do have that symptom. I didn't even know joint pain was a symptom, or I didn't even know headaches was a symptom. So usually you can squeeze out a symptom from someone. But there are a lot of women who come in and they, have read the books and they know there are heart benefits and stuff. So as long as they know, we don't really know how much benefit you'll get and if you'll potentially have a benefit, because if we don't know, so if someone has, let's say, microvascular disease in their brain, we can't prevent dementia if you already have something starting. So as long as they know, we can't guarantee they'll have all the benefits, then I will prescribe it.
Okay, that's helpful.
Yeah.
Really, there was a question of just, what are we protecting in the uterus when we take progesterone?
Right. So estrogen is what we call proliferative, and it makes the lining of the uterus thicken. Now, every month when we're getting our periods, our bodies are preparing to get pregnant. That's what our bodies think is going to happen every month. So the estrogen helps to thicken our lining so that we can welcome an embryo. And then when we don't get pregnant, it's the progesterone that sheds that lining. So if we only had estrogen, the lining just thickens, and there's nothing to potentially stop it from changing over to precancer or cancer. So progesterone is the hormone that sheds the lining of the uterus and keeps it thin so that we don't overgrow our lining.
Okay, thank you.
Yes.
There's a comment here, and I'm going to call it out because this is the soapbox, and this is like why we're doing what we're doing. But thank you to Brooke for sharing that she had to fight with her insurance company to cover her vaginal estrogen. They said it was a vanity drug, which that's just that is part of what we're doing while we're doing. And thank you for joining and sharing. That is not true. It is a life-saving.
It's actually life-saving. If you listen to Dr. Kelly Casperson, who is awesome, women you can get recurrent UTIs from lack of estrogen in the vagina. Women with recurrent UTIs can end up in a hospital. They can end up getting up at 3 o'clock in the morning to go pee because they have urgency and frequency, and they can fall and break their hip. So it is not vanity. It actually is a necessity for a majority of women to have vaginal estrogen. It's not vanity. And it's not just sex we're talking about, but it can cause painful sex, vaginal dryness, even outside the vagina gets atrophied, and women just have irritation, pain. I have a woman who says, I can't wear jeans anymore because the outside of my vagina just hurts. They need vaginal estrogen. And for someone to say it's vanity and you have to fight for it, it actually infuriates me.
It really does too.
It's just
I have to call
wrong.
that out and thank you. There are more stories coming through like that. And it is, this is a time actually we'll call out. So, part of Let's Talk Menopause is, we are advocating and championing women's health, and especially in Washington. So we have, an unboxing, it's called Unboxing Menopause, which is we're writing letters to the FDA to remove the black box warning from local estrogen, which has, it's really misrepresented just what the safety of local estrogen is. And so we are advocating, thankfully, hopefully we might have some, we have some allies in Washington, and we might be able to see some changes pushed through around removing that black box warning, because it has created scare tactics for far too long for women. And please sign the letter. Donna is including the link. We have, thousands, I think we have 16,000 and counting folks who have, it's very easy. You just go on, you put in basically your name and email and details, and we will send a letter to the FDA on your behalf to advocate for women everywhere.
Yeah, please.
Can we talk a little, speaking, you brought up Dr. Kelly Casperson. Can we talk about testosterone very briefly? There's some women here who have shared that they're on it, and a little bit of how women can think about testosterone, since that is becoming more center stage.
So testosterone is also a question we get very frequently, and there are tons of benefits from testosterone. Right now, the indication to prescribe testosterone is for low libido. But I have women, when they come in, they want estrogen, progesterone, then testosterone. But I tell them, many women who have low libido could be not necessarily a testosterone problem, but for many women, if you're having hot flashes, night sweats, and you're not sleeping, and you're fatigued, you don't want to have sex. Your brain is trying to protect you. And also, when you're having vaginal dryness, pain with sex, your brain is trying to protect you. It doesn't want you to have sex if it knows it's going to hurt. So I always say to women, let's treat your menopausal symptoms first. Let's get you sleeping. Let's get you feeling better. Let's get your energy back. Let's fix your vagina. And if after doing all that, there's a libido issue still, then we talk about considering adding testosterone therapy. But for right now, it is really just used for low libido.
Okay. There was another question around DHEA. Well, the specific question, but also just if you could expand on what DHEA is, was can estradiol vaginal supplements be taken with vaginal infibrosa, or DHEA?
So DHEA is the hormone precursor to estrogen and progesterone. So DHEA is broken down to estrogen and progesterone and testosterone in the body. So a lot of women are taking the DHEA supplement, which is over the counter, hoping that it'll increase their testosterone levels. We don't really know. Again, it's a supplement, so you don't really know what you're getting. Are you getting the dose that the bottle says? We don't really know. And without actually checking your levels, you don't know if your testosterone is actually even low. So the DHEA supplement is questionable if women take it over the counter. I think it's okay, but it doesn't help everybody. But there's also a DHEA for the vagina. So I mentioned vaginal estrogen. So there's vaginal estrogen, the ring I told you, it's every 3 months. Local estrogen, there's a tablet, there's a cream. There's also something called intrarosa, which is DHEA. So most women respond to vaginal estrogen, but there are some that also need testosterone in the vagina. And it's a great way of getting them testosterone in the vagina. So when you give them the DHEA in the vagina, it's converted to estrogen and testosterone. So they're getting both in the vaginal tissues, and it works very well.
Perfect. What can you talk a little bit about why practitioners don't want to check hormone levels? And then there was also a question around what should FSH or progesterone or estradiol, what is the ideal range, at least at the start? So,
well, the problem with hormone levels is they're not accurate. Hormones fluctuate day to day, week to week, depending on where you're at in your cycle. For example, estrogen and progesterone are not like a thyroid hormone, where when you go to your doctor, they check your thyroid, they may adjust a medication based on your level, say, come back in 3 months, and they check your level. That's a stable level. Hormones don't do that. So even on a good day, even with someone that doesn't have symptoms, your estrogen could be different levels throughout the day. Your progesterone could be different levels throughout the day, throughout the week, wherever you're at in your cycle. So it's not accurate. So when we're talking about FSH, so FSH is what we call follicle stimulating hormone. If it's over 20, that's in the menopausal range. But you can go to your gynecologist in February. You can miss a period for 2 months. We can check your FSH. It could be 30. So you think you're in menopause, and then 2 months later, your period is back. And if we checked your FSH again, it could be 3. So they fluctuate. They're not accurate. The only time we rely on or check FSH, let's say, is if someone doesn't have a uterus, so they don't have their period, they have the IUD, and the patient wants to know if they're in menopause, they don't have symptoms. Then we check. And I always say to women, if your FSH is elevated, I would recommend repeating it in like 3 to 6 months. If it's still elevated, then yes, you're most likely in menopause.
Okay.
Yeah.
So I love this question, but what can I do to prepare for perimenopause and menopause? Is there anything medically I should be doing, but also lifestyle? I'll add lifestyle.
Well, that is an awesome question, because I say, besides the fact that us as gynecologists, we don't address perimenopause and menopause well at all, we're even worse at preparing women to know what to expect for the next phase of their life. We have in 5th grade, you have your lecture about what to expect when you get your period, and then when you're pregnant, you have Lamaze to, what to expect when you're pregnant, but nobody prepares you of what to expect when you start having changes or symptoms. And what a lot of women don't realize is they think I'm not going to go into menopause until I'm like gray haired and old. But average age of menopause is 52. Perimenopausal symptoms can start 10 years earlier. So if you're going to go into menopause at 52, you could potentially start having symptoms at 42. But what if your last menstrual period was going to be at 45? You could start having symptoms at 35. And most people don't think it's perimenopause. I'm in my 30s. Like, it can't be. So I think what's very important is that women just realize that any symptoms that you have, any cycle changes, any symptoms could be perimenopause. So it's important that you just recognize your symptoms and advocate for yourself. Because yes, you're going to go to a gynecologist and they're going to say, so do you have periods? Yep, every month. And they're going to poo-poo you and say, it's probably not perimenopause. But that is not necessarily true. And while we're on birth control, a lot of women say, I'm on birth control pills. Like, how do I know if I'm in perimenopause or menopause? Well, while you're on the pills, you wouldn't know, because they would be treating your symptoms anyway. So being on birth control is actually probably helpful, because even if you were going to be in perimenopause, you wouldn't have the symptoms and you feel pretty good.
Yeah. Are there specific, what are some of the annual tests? And I don't mean just specifically hormone levels, but how, to live well.
Yeah.
It's very broad, but maybe starting at the 40 and above.
At what age you say starting at 40 and above?
40 and above, I think, is probably.
Yeah. So everyone should be seeing a gynecologist yearly. You should be having pelvic exams yearly, not necessarily the PAP. The PAP could be every 3 to 5 years, depending on your history of PAPs. But if you have normal PAPs and negative HPV, but you still should be having a pelvic exam once a year. You still should be having breast exams once a year and yearly mammograms. You still should be assessed every year for STDs, birth control. A lot of women come in for their yearly, they're 42, and I say, what are you doing for birth control? They're like, nothing, I'm 42. I'm like, you can get pregnant. So it's really assessing all those things. And then us as doctors, we're asking you other questions. So you may come in for your yearly exam, but if I find out you are having chest pain or other symptoms, then yes, we may have to refer you to another doctor. But just general health things are important. Seeing a primary doctor yearly, having your cholesterol checked, screening you for diabetes. So just having your general wellness is very important.
Yeah. And we're talking, I mean, those are call it the physical checks, but also mental health as well.
Absolutely.
Or behavioral mental health. One of the very common questions we get, and that was a big one, especially at our annual Menopausium in Dallas that we saw coming through, was around how menopause impacts your cognitive function.
Yeah.
A lot of women say, I feel like I'm now ADHD, and obviously,
Yes.
whether it's self-diagnosed or finding it. So how do you recommend kind of addressing your either brain health cognitively as well as just mental health?
I think it's very important is to not be embarrassed of it. So a lot of women are embarrassed to admit it. They'll be like, oh my God, I was at work, I was giving a presentation, I forgot what I was saying, or or I feel like I have ADHD now, and women are embarrassed by it. So instead of either talking to other people or talking to their doctor, they get embarrassed. Am I getting dementia? Am I going crazy? Is there something wrong with me? So I think the problem is a lot of women are embarrassed and then they hide. They hide those symptoms or cover them up. So when you forget something, we're all self-deprecating, make a joke and like, oh, I forgot, whatever. But we're just afraid, we're embarrassed to admit it, but it's a normal thing that happens and something that absolutely can be treated.
Okay. So moving down also the list of things to take care of, sexual health. Sexual
Yeah.
health, also a big part of general overall health and wellness.
Yeah.
Either broadly recommendations on taking care of your sexual health and how to check up. And then there was a very specific, which I know we had talked about before this, of excruciating orgasms before a period. So painful sex, and very specifically painful orgasms, but also just painful sex, which I think a majority of women actually experience as they enter into menopause. So
well, first of all, yeah, just like the symptoms of, brain fog and stuff and being embarrassed, I think it's very important that we normalize talking about sex. You go to a cardiologist, they're not embarrassed to say, hey, any palpitations, any shortness of breath. But the second you say vagina or you want to talk about orgasm, everyone cringes, even the doctors, they don't want to talk about it. But it's very important that we normalize that conversation. Sex is normal. Sex is important. So A, be able to talk about it. B, if you go to a doctor and you try to bring up your sexual issues and they don't address it, then you have to find somebody else because you need to feel comfortable talking about that. So that's extremely important. The other thing that's very important to know is whether you're 20 or whether you're 50, pain with sex is not normal. So any pain with sex needs to be evaluated. You can have pain with sex, and how do you know you don't have an ovarian cyst? Or how do you know you don't have a vaginal condition? You don't know. Or how do you know it's not something simple like vaginal dryness and you just need some vaginal estrogen? So it's very important that any pain with sex is not normal and needs to be evaluated. And some women say, well, I've had sex my whole life. It's never going to change. Well, that's not true either, because we have so many more things available to us now. Now there's so many women are getting what we call pelvic floor therapy. They're a pelvic floor specialist. So they're getting therapy for their pelvic muscles. And there's also specialists that can treat certain things like certain conditions that cause pain with sex. Now you can go to a doctor and get injections in certain muscles, but there are treatments now that nobody even knew existed. But if you don't ask, you won't know that.
And there are, to your point, dedicated practitioners. It can be
Yes.
hard and it feels overwhelming to have to build out
Yes.
a whole care team, but once you have that in place, right? Be it your cardiologist, your endocrinologist, your
Yes.
gynecologist, it is kind of the most important to build out that SWAT team of people who are taking care of you and with you during this transition and beyond. There was a question around very quickly brain fog and how do you distinguish between whether it's brain fog or potential onset dementia and Alzheimer's. I will say, and this is a plug, we're looking at July of actually doing a whole dedicated menopause talk on this, because actually we've done surveys and it is the #1 requested topic that folks are curious about and want to learn more. So but really quickly here, how to distinguish between general brain fog as a result of hormones fluctuations versus early onset dementia or Alzheimer's.
So very common question. It is very common. It is a extremely common symptom to have brain fog. Most of the women with brain fog do not have dementia or Alzheimer's. You're right. How do you know? So what I tell women when they come in, they're convinced they have Alzheimer's or dementia. I say, most likely, statistically, you don't at your age. But the only way to know is if you give hormones a try. So unfortunately, there are no non-hormonal medications for the brain fog symptom. But I say to women, let's go on the hormones for 3 months. When you come back, if your symptoms are not better, then yes, we can always send you to a neurologist and check. But majority of women with brain fog is from the hormones. And in my years and years of doing this, I have not had one patient, and I'm not going to say they don't exist. I personally have not had one patient that came in with brain fog symptoms that turned out to have Alzheimer's or dementia.
Wow. Interesting. Okay.
Doesn't mean they don't exist in the world, but majority of women truly have a side effect of brain fog.
Okay, yeah. And there are still, as we know, we don't know enough yet around
Yes.
dementia and Alzheimer's. There's a lot of research. I think there's a new blood test that's coming out where you can actually test in the blood for Alzheimer's. And we do know that women experience Alzheimer's at a rate of two times the rate of men.
Yes.
But just more research to be done, and regardless, advocate and, like you said, find a provider.
Yes.
I know we are about to, we might end on that because it might be a good plug for, we'll share a little bit of what we're doing in June, but also July. Thank you very much. I know there are a handful of additional questions. We really covered a lot of ground here. Maybe Dr. Soviero, just to be able to end on, I love this because it's a lot to learn and take in. Maybe what are the 2 or 3 actions you suggest every woman take to start prioritizing her hormonal health, or how do you just get started?
Well, paying attention to your symptoms. And once you have symptoms, knowing that it's something you have to talk to your provider about, and not all gynecologists treat this. And I understand why. I could go into an hour why they don't, but not all gynecologists do. So maybe before you go to your doctor, you could even call the office and ask, does the gynecologist do hormone therapy? Do they treat it? So that you can not waste as much time, and hopefully just find someone that'll just listen to you and advocate for yourself. When you go to somebody, if they say to you, nah, it's not your hormones, or nope, can't have hormones, they're dangerous, then know that you deserve to speak with someone who is going to give you all your options, talk to you about all of your concerns, and you need to find someone that will help you.
That's great. I know that Donna has put those links in there. We have a symptom tracker that we have built with our medical experts to just begin tracking what's going on with your body. There is the link to the finding a practitioner. Thank you, Donna, for putting it in there. But there are, please, there are actions you can take to take control of your own hormonal health. But thank you so much, Dr. Soviero. This was so informative. We really appreciate your time here. And appreciate everything you do for women. The survey, just as we're wrapping up here, the survey should be live in Slido. Please fill it out. We really read every single comment, every single piece of feedback to help inform future talks, and to continue to iterate. So please, please, please fill that out. Also, please send that letter to the FDA in support of our Unboxing Menopause campaign. No woman should be told that this is a vanity prescription. But still, my blood is boiling from all of those who shared. So please join us as both as we think about how it's just to remove that black box warning from the boxes. And then also, we invite everyone to come to our next menopause talk with double board certified orthopedic surgeon Dr. Vonda Wright on Monday, June 16th at 12 p.m. Eastern time. We're excited to be going into everything from joint pain, frozen shoulder, and really how to build out a strength training routine to make sure that we are investing in our bodies and living well. For both from our bones all the way out. Thank you everyone for joining us. Hopefully getting a couple minutes back before your next meeting or whatever is next. But thank you so much for spending time with us, and have a wonderful rest of your day.